Alright guys, I asked what today's vlog should be about, and the majority of you said rounding and signing out patients. So I'm going to give you 7 tips on how to successfully round and sign out your patients without getting shitted on by your residents. Let's do this. I feel like everybody pretty much knows how to round on patients and how to sign out patients, but I want to give you tips that not everybody exactly thinks about. So first tip, number 1, know what happened the night before. If you're coming in at 6 a.m., 5 a.m., whatever it is, to work a day shift, find out what happened the night before from nurses, from the student that was on call. The resident might not, who knows what residents are like at different institutions, but the student and the nurse, find out exactly what happened. If the patient complained, if she had some random pain in the middle of the night, and she had to get an extra dose of pain medication, if anything happened, find out the little details, so you can seem very well informed on your patient, very knowledgeable about what's happening in their treatment. Alright, tip number 2, we all know we need to know the vitals, we all know we need to know the lab values. If they got a CBC, CMP, whatever they got, you need to know the trends. You need to know that their hemoglobin is going down. You need to know that they had a fever in the middle of the night. Their AST, ALT is elevated. You need to know. If they had troponins drawn, you need to know when to draw the next troponin and what the troponin levels need to be, how many troponins you need to draw. I always end my interview with the patient with, do you have any questions for me, or do you have any questions for the doctor? So when you go back to the resident and you're presenting to the resident, you say, oh, and the patient mentioned this, and the patient would like to know about this, this, and the other. It looks like you're so involved, like you really know what's going down with this patient, you really care about his or her care, and you're looking out for them, you know what I mean? Okay, tip number 4, whenever you do a history with a patient interview, it should be accompanied by a physical. We need to do a focused physical exam. Talking specifically about OBGYN, I don't really care if their elbow hurts, you know what I mean? If someone had a C-section, I'm checking the incision site. I am asking about bowel movements, if they passed gas, because your bowels are manipulated during the C-section. If they had a vaginal delivery, I'm asking for lochia, which is vaginal discharge. Or I'm asking for C-section, I'm asking if they're using their incentive spirometer. I need to make sure that they're recovering well from the surgery. This one's a pretty big tip. It's for the actual presentation. You want it to be in SOAP note. So SOAP, so the S part is subjective. This is everything the patient tells you. So your baseline statement is, this is Mr. John Doe, 56-year-old male, presents for abdominal pain, admission day 4, whatever. Then SOAP. He's been complaining about consistent abdominal pain in the left lower quadrant. Patient also states dark stools. Like, you can just say whatever the patient says. Whether or not it's medically accurate, that is what the patient said. So O is objective. This is where you start off your physical exam presentation. So you start off with the vitals. You say whatever blood pressure, respiratory rate, heart rate, temperature, whatever I was missing there. Then you go to the physical exam, focus physical exam in a head-to-toe format. So if your focus physical exam starts with the chest, then that's where you start. For OB, we start a lot of times with in the chest area, so we either start saying the heart, S1, S2 present with no additional heart sounds, or we start talking about the breast and we say soft and non-engorged, no tenderness to palpation or something like that. But it always starts head to toe. And then A is your assessment. So again, you give the baseline statement. I don't remember what I said the first time. 27-year-old Jane Doe female presents with chronic shortness of breath, admission day 2. You go through her, then you go through her problem list. Like, she has shortness of breath, additionally whatever she has. Sorry if that cut looks weird. Someone just walked in. I'm in the nurse's lounge right now. The last part is P, plan. So how are you going to fix this patient? So your plan should be associated with your assessment. And typically we don't separate it. We don't list everything that's wrong with them and then list it again with the treatment. So we list shortness of breath, we list treatment. We list abdominal pain and then treatment. You know what I mean? and that's how it goes. It shows, it should be a very quick, comprehensive review of this patient. After you're done with your SOAP presentation, the next team, when you're signing off, should know exactly what the patient is feeling right now, what actually is happening objectively with the lab values and her vital signs and the physical exam, what her problem lists are, and how we're solving them. For example, if you presented yesterday and there was something additional on the problems list and it's resolved today, you would mention that and the team would know that, and we can move forward in her treatment. Just waiting on the plane to pass. Come on. Next tip, I feel like we're just like on a theme of just knowing the patient. Like, basically that's it. You need to know the patient. So the next tip is knowing the plan, knowing what comes next. You set the plan in your SOAP note, so you need to know why we're doing these things. If someone comes in with unilateral swelling in their lower extremity, you think they have a DVT, the plan is to do an ultrasound. If a resident asks you, why would you do an ultrasound, you need to know why that's happening. And this actually goes along with the following tip. Let's just combine those together. Research the pathology. If someone comes in with chronic heart failure, know about chronic heart failure. So if anybody asks you any questions about chronic heart failure, you know everything about it. You know the etiology, you know the risk factors, you know the treatments, you know? Yeah, I think that's all the tips I got, guys. I hope this video wasn't too long. Honestly, I don't really know at this point. I haven't edited anything yet, but I hope you guys appreciate it. I'll see you guys next time.